patient than somewhere else. All the upper teeth are in bad condition. You see, there is no, so the premolar.
Canine.
There is no canine on both sides. Okay. This molar has been rotated too much here. This probably must be 1/8. So where is the canine? It is impacted. There has been severe inflammation, severe gum bleeding in all the upper tooth and lower anteriors. See, the gum is at the level of CEJ, but the bone is present only near the 4 mm apex of the incisors and molars. So this kind of clinical appearance will cheat the doctor and the patient. They think that it is okay. Sometimes when the bone resorbs, the gum also goes along with the bone. But here, sometimes the gum stays at the gingival level, but the bone alone visits. You can see only the incisors, they have been came very much down, right? The premolars and molars, they are in different level. Maybe some kind of roller coaster effect. Okay. So poor orthodontic planning is the first thing. Right? The canines are still inside the bone. Okay. The canines are still inside. How the roots of lateral and premolar will move properly. Right? So these canines, the impacted canines, they are interfering with this movement. That will lead to either root resorption or bone resorption or untoward tooth movement. Okay, either the canines should have been brought to the occlusal plane or they should have been removed. Right? So we will see the, this is the lower. So one premolar is missing from this side, right? So both side premolar is missing. There is no braces in the lower, right? Only braces in the upper. So there is no occlusion here. So this is the classic roller coaster effect. Right? So we'll see the so we see now. We'll see first the parallel view. As we can see, both the canines are impacted. The right canine is almost the crown is poking into the nose nasal cavity. The canine is moving upwards, right? There is no way it can be brought down. See, the root is interfering with this premolar. This crown is interfering with this lateral premolar. Okay. The sinus is clear. 1/8 is impacted. This is 2/8. 2/7 is missing. You can see severe bone loss in 6 till the apex. You can see the interdental calculus also. So patient hygiene also is bad. Treatment plan and treatment execution. So all lead to it's kind of upward full mouth. Even the lower looks very bad. All the premolars and molars till furcation there is no loss. Unfortunately 7 is single rooted tooth. It won't come for a long time. The lower anterior also clinically they are not good. So ideally it is a full mouth. Going for full mouth will be beneficial plan considering the age and future of the patient, but we are planning for only the upper one. Okay. So if you see the observation, this is a nasal floor, this is the root apex. The root apex is almost close to the nasal floor. That means the amount of basal bone available itself is very less, right? So whenever the root apex is close to the nasal floor, it becomes a challenging situation. Here placing pterygoid may be a challenge because it is impacted eight after removing the impacted eight. Here the pterygoid looks good. Okay. So anteriorly the available bone is less because the basal bone available beyond the apex is less. And getting anchorage from the nasomaxillary buttress also is not possible or difficult because the canine is occupying the exact nasomaxillary buttress. So this is the nasomaxillary buttress. So this is the nasal cavity, this is the sinus cavity in between this triangle bone. Here also the canine is slipping here. So we have to decide whether we are going to remove this canine. Definitely left canine we have to remove because it is closer to the crest of the bone. This canine, whether we need to remove or we can keep it, we have to decide. We'll see the reformatted image. So, you know, the canine is like the person traveling in bus, in the steps. One of will be outside the bus and one of will be inside the bus. He is traveling partly inside the nasal cavity and partly outside the nasal cavity. So if you palpate here, patient extraorally, you will feel the bulge. Okay. It is exactly in the nasomaxillary. You cannot take anchorage. Even if you retain it or not retain it, you cannot use this bone. You can use this part. This part you can use. Here that is also not possible because this canine is lying here. After removing canine, we can place implant maybe here. We can see the bone available is very much less. This is the apex. Above the apex only 1 mm is there. So it is a very challenging situation. So ideally this kind of situation will require zygoma. Okay. So the zygoma is very close, zygomatic prominence. The buttress is very close to the ear. So this is the pterygoid here. See the 8 is buck out here, right? So after 8, the pterygoid junction is near. But here, after you remove this 8, the pterygoid is little far away because the 8 has been easily migrated. See the amount of palatal bone loss in 2-6, right? So we will plan first the pterygoids. The easy pterygoid is of course the lateral pterygoid. This is the 8, right? This is the classic pterygoid view. Even in IUP you will see this, right? So this is the junction we have to name for this part. So this is the tuberosity, this is the sphenoid bone, pterygoid process, this is the junction area. So if you start the drilling just behind the 8, almost like a 40 degree, we can raise this part. Okay. So this is the mesio-distal, this is the bucco-palatal. So if you go like this, you will enter the mesio-distal. Ready? So slightly medially tilting. Okay, that is good bone. You will see the 3D view. So this view is the mesio-distal view, right? This is also mesio-distal view. This is the bucco-palatal view. So all these three views you can see. So you have to imagine in mind. Okay. You should not feel dizzy. Okay. So 18 mm, 19 mm, 21, 20 mm implant we can place. What we are going to do is, if we are tilting the implant little more distally, convolution, suddenly the amount of bone available becomes less, right? Okay. If you tilt too much, then again it becomes less. So that is the trick here. More horizontal angulation will lead to less available bone. So this is the criteria. So if you go on, no, you will reach the brain here. This is the base of the skull. You will see. Okay. This is the base of the skull. Okay, so we don't need to go to here. The maximum available length of implant, regular implant is 20 mm. So wherever you are feeling the drop, you can pressure on that. So this is the pterygomaxillary patient, this patient. Okay, so the left side pterygoid is done. You will see the right pterygoid. So this is the southern conical root. You can see the sinus septum here. Okay, so this is the 8 perifollicular space is there. So removing is not difficult. The more the perifollicular space is there, it is easy to remove. So where to start the drilling? Just behind the seven, right? The thing is only this part will be covered by bone, this part will be an empty socket. So that is a drawback. You will see the 360 degree view. Only this 50% is inside the bone. But this part will be, palatal it will be covered by bone, but buccal it will be exposed. So we have to decide whether you have to use a BC's design or compressive design. Using basal design is also a good idea because there will be only shank here. Okay. The number value is good HU unit. Okay. Around 1500 in one spot. You will tilt it more distally. Okay. The more vertical you will be inside the sinus, the more horizontal you will be on the less bone area. So it should be in between. This is the important trick. So we will see the 3D reformed view. So the right side pterygoid is over. So removing, we should be careful, we should not push it into sinus or pterygoid space. Now we'll see the anterior implant, 112 implant. Very poor situation here. Okay. See, beyond the apex there is nothing is left. 2 mm bone is there. When this bone is only 9 mm, right? Labally on thin plate and palatally on thin plate. So ideally it should be a quad-zygote, right? So now we are planning with multi-unit single piece. So where to place implant here? See the nasopalatal canal also
Wide.
very wide. That is also bad. So what we can do is, we will see the value. It is around 1500. The nasal floor is around 1500. If you use a compressive implant, the tip will be very much sharp, right? Tapered design. It won't get good stability from here. But if you use a BCS design, you will get some stability. When you connect all the implants with titanium bar, this system will work. So the value is around 1500, 400. Though it is only 1 mm, 2 mm bone, the value is 1600. So we have to use BCS design. Multi 3.612. Or there is one more option. You can shift the entire implant to this interdental area between 1 and 1. Okay, here socket is not there. Okay, so we can place a compressive implant here. Okay, either you can place 10 mm implant, we can place, or we can place like this vertical approach, 10 mm or 8 mm. Of course, it looks like 8 mm. Okay, let's see the 360 degree. Of course, if you see here immediately the socket comes. Here the nasopalatal now comes. This is the central. This is canine. This is nasopalatal. Okay. This is one option. We will see whether we can place an anterior implant. That is also tough because the canal is wider and the two teeth are close to each other. Because of ortho, no? They become. We will see. Okay, not very great, somewhat okay. Here also we can place it. It a down implant. Here also palatal approach. Okay, middle implant. Or 1-1 implant BCS, or between 1-1 and 1-2 compressive. So these are all the various options we are discussing now. We will check the 2-1. 2-1 also will be like this, very poor, right? The nasal floor is around 1600, 2 mm only. We can place a BCS or we can place a compressive in between 2-1 and 2-2. No, that is not possible here. Placing implant between 2-1 and 2-2 is not possible because they are very close to each other. Right? Because of this impacted canine, this lateral root is very close to. So placing a implant in between 2-1 and 2-2 is out of question. Okay. You cannot place implant in 2-2 itself because above 2-2 the impacted canine comes, which we are going to remove. Okay. So beyond 2-2 we are checking. Beyond 2-2, of course the canine root is coming fully. Not ideal scenario. So we are checking in the first premolar. First premolar somewhat okay. It is also bad. Because crustally only 2 mm bone is there. After that the socket will come. After that only nasal floor 1 mm after will come. We will check between 2.4 and 2.5. Here somewhat it looks okay. Here there is bone, the buttress area. Okay. So between 4 and 5, we can place this slightly easily tilted implant. So here only the root socket will come, which will be very less instead of the crown area where the defect will be more. Or one more thing what we can do is we can remove only the canine, and we can leave the root, and we can go through the root. We get excellent stability. Right? We can drill through the root. That is also possible. So this implant, it looks good. We'll see the 360. Okay. If you remove the canine, definitely there will be very close to the sinus. Actually, the root is projecting into the sinus. So in between 4 and 5, slightly easily tilted, we are in good mode. We'll just check if we are not tilting here straight. If we are not straight, we will go into the sinus. So tilt it slightly easier. So this is the only savior on the left side. Okay. So left side, we'll check any other option. In the 6, not at all possible. Between 6 and 7, maybe some small bone is there. Okay. Maybe 8 and 11 meter we can place. In between, we'll see the 360 degree. Slightly towards Maxillofacial, you will get some more little longer length. Okay, it looks okay. Just in front of the 8. But of course, we are going to place pterygoid also. These two will interfere with each other, the scan bodies, everything. There is no great advantage in placing this implant in between. This pterygoid is more than enough to take the load. And this one buttress is enough for that segment. So there is no great advantage in placing this implant. It will complicate the prosthetic procedure actually. Okay, this scan body will come easily. This scan body, no. There is no big use here. Maybe we can tilt it slightly easily so that both the pterygoid and the smaller implant will tilt easily. So the main problem is we don't have a good bone from 2-1 to 2-4. That is the challenge. The anterior segment. So one option is we can place implant in the midline. Okay. Okay, placing one implant in the midline. Of course, it will be a very short implant. Okay, either axially or parallel approach, like this. So, if you avoid palatal approach, you can get some stability from the vomer bone. This bone. This is the, can you see this shadow? You can get some bone. You can place even a longer implant. Exactly in the midline. So this bone. This middle bone. This is the over one, right? In this, you can get this will be a better idea. Okay. So left side is middle implant and this is maxillary buttress and the pterygoid. If needed, we can place this slightly easily and get the molar implant. Now we are coming for the right side canine area. We'll see. So here this mesomaxillary buttress area is occupied by canine. So we can go till here, right? 4.2 to 12 it shows, 13 we can place. Sorry, it is not, it is the canine, no, it's the first premolar area, right? We will try from the second premolar. From the second premolar, you will be entering the root, right? So beyond second premolar, there is no bone. Maybe in palatal root, right? There is some good bone in the 6.
5.5.
5.5. Yes, 5.5 also we can place. That means we have to go for a simple diet. 5.5 basal design. Or if we tilt it slightly distally, we are in some good bone, fortunately. That is also possible. Actually, this kind of bone won't be present, but here it is present. So one pterygoid and one more. It's a kind of palatal bone from 6 tilting distally. Okay. So almost like a 2 pterygoids here. So totally how many implants now? Leave this molar implant.
5.
Left side 3, including the middle implant, right side 2. One implant we need in the premolar areas. So from the first premolar, if we tilt implant distally, okay, we will get some good bone, and we are entering the root, apical end of the root, which is quite easy. From first premolar tilting distally, or from second premolar straight. Okay. The problem here is after removing it will be the empty socket. So the implant will get stability only from this impacted canine root. So this may not be a good idea. So the proper plan will be either this one in between 4 and 5. The implant will get stability from this bone around 10 mm. Beyond that, it will enter the canine also. Okay, otherwise, we have to remove this canine. We have to go beyond the canine, and beyond the canine, there is a bone is there. We can cast it. Long implant we can use. So this part will be into the socket. So for that, we need to remove this canine also. The problem is, while removing the canine, we may remove some bone. It is the problem. Here we may create a window, no? So that will destroy this good bone. So while removing, and we have to be careful about the infraorbital nerve also. So we have to plan whether we have to remove this or to retain it. Because this is going upward direction, the exit path will be upwards only, superiorly. Right? At least we can do coronectomy. Right? Because any pathology coming from canine will be from the perifollicular space. Perifollicular cells, they may differentiate into any kind of growth or tumor in future. So better what we can do is remove the left canine fully, right canine only coronectomy. The coronectomy is an acceptable procedure. So getting stability from root is also accepted. It is working good. So either we can get stability from only this part of the root without invading the pulp, or we can go through the pulp and beyond the pulp and go there till here and get stability through and through preparation. So we need 2 mesomaxillary buttress area, 1 middle implant, 2 pterygids, other 2 are additional, right? And additional implant we can try in the canine area. Check. It's not good, right? Maybe we can do some parallel approach like this. But this is enough. If you place this getting good decent stability, actually we don't need this intermediate implant also. This 5 implant is more than enough, provided all are good. All are 5. So we'll see.